Okay, we're here. So let
Okay,
me know.
we can start. Sure. So thank you for joining us, everyone. My name is Trish, and I'm with SK Life Science. I'm also a volunteer for several years here with the Epilepsy Awareness Expo, this fabulous event. We have Dr. Mona Sazgar. Delighted to introduce her. Today, she's going to give a talk, as you see, on the treatment of women with epilepsy. For those of you not familiar with Dr. Mona Sazgar, she's an epileptologist and part of the team at UC Irvine Comprehensive Epilepsy Center in Orange. That actually level 4 center is a state-of-the-art clinical research and surgical program. And Dr. Sazgar is a renowned epileptologist, a specialist with advanced technologies and therapeutic treatments to diagnose and treat epilepsy patients and the hopes for seizure freedom. So thank you, Dr. Sazgar, for joining us today and talking on one of your topics that you're very passionate about with women here in epilepsy, and the floor is yours.
Thank you, Trish, and thank you everyone for joining us and listening in. This talk is on treatment of women with epilepsy, and that's, as Trish said, is my passion. So I am very excited to talk to you today in this matter. Let me just, there's going to be the multiple screens in here. So let's just start with a case. This is a young woman, 28-year-old, with a long-standing history of focal epilepsy of right frontal lobe origin. And the reason for her epilepsy was found to be some abnormal brain tissue there. We call that cortical dysplasia that she was born with in that right frontal area. She used to experience her seizures a couple of days before the start of the menstrual period, and then it would go throughout the menstrual period. And some of her seizures progressed to generalized tonic-clonic activity. In the past couple of years, she gained complete control of her seizures on oxcarbazepine, 900 milligram twice daily, and did not report any further seizure activity. She was put on folic acid the moment that the neurologist found out that she's starting to date someone, and then she got married a year after that, and was taking birth control, which was a combination of estradiol and progesterone. Now she comes to a neurologist, and she informs her that her pregnancy test came positive. She's almost panicking because she was on birth control. She didn't expect to become pregnant. She also started experiencing a couple of auras, which worries her. She has a ton of questions for the neurologist. What happened? Why am I pregnant? What's going to happen to my baby? Is it going to be fine? Like, not that it happened accidentally. What would be the effect of seizure medications on my baby? What do I do? What would be my future directions? That brings us to the talk on women with epilepsy. Women with epilepsy face, as you are aware, a number of problems that are unique to their gender. These concerns relate from the time that they start with puberty, from menses, birth control, conception, pregnancy, childbirth, childcare, and eventually even menopause. So any changes in their hormone can affect their epilepsy and can affect the seizure medications that they are on. The outline of my presentation is that I start with defining catamenial epilepsy. Then I will go and talk about oral contraceptives and seizure medications, and what happens to the seizures during pregnancy. Do they get better? Do they get worse? What is the course of epilepsy during pregnancy? Then we talk about use of seizure medications during pregnancy and benefits of folic acid supplementation, and then also breastfeeding and seizure medications. As you know, epilepsy affects about 1% of the population. Half of epilepsy population are women. That means that about 1.5 million women in America they have epilepsy, and these people mostly are in childbearing age. Of all of these people, 24,000 give birth each year. Many healthcare providers, when they actually send out a survey to them, were not aware of any specific women issues. When they talked about like, do you know even if the hormones affect seizures, or which birth control forms will fail if you are on certain seizure medications, or like all of those questions, they had absolutely no clue, and they responded that they were not aware of it. That brings us to the fact that we need to have more education, even for healthcare providers, let alone the people with epilepsy, women with epilepsy. What is catamenial epilepsy? The word catamenial comes from the Greek word catamenius. Catamenius means monthly. As far back as 1800s, people knew about catamenial epilepsy. There was Sir Charles Lockhart who described that some seizures are associated with menstrual periods. That was 1857. And then there was Sir William Gowers, who was a physician, British physician in 1881, that noted that the majority of women in his practice, the women who had epilepsy, they had worsening of their seizures perimenstrually. So what is catamenial epilepsy? Catamenial epilepsy is when pattern of seizure fluctuate with the menstrual cycle. Seizures may increase in certain part of the menstrual cycle. It could be around the time of menstruation, around the 2 to 3 days before or during menstruation, and that is because of rapid decline in the progesterone. Seizures may also increase at the time of ovulation, and that's because the estrogen, the bad hormone for epilepsy, peaks at that time. Seizures can also increase for people who don't have ovulation if the ovulation does not happen for the entire second half of the menstrual period. So for like about 14 days after ovulation, if the ovulation does not happen, then they can have worsening of their seizures. What is the prevalence of that? 33 to 39% of women with epilepsy have medically have catamenial epilepsy. So that's about up to 40% of patients of women with epilepsy. This graph is what Dr. Herzog in one of the publications published, and a lot of us who deal with catamenial epilepsy and we treat women with epilepsy, we use that to explain the time of worsening of the seizures. So as you see, day 1 is the first day of menstrual cycle. From -3 to +3, these are the time, so 3 days before menstrual cycle to 3 days after. This is called C1 pattern of catamenial epilepsy. Then you have from day 11, which is right, like if you go back from day 1 of menstruation, 14 days, that's the time of ovulation. So -14 is actually the day of ovulation. And around that time, 11 to -14 is the C2 pattern. So these are the people who have worsening of their seizures around the time of ovulation. And then the graph on here is showing if ovulation does not happen for the entire second half of the menstrual cycle, they have worsening of their seizures. How do we determine if somebody has catamenial epilepsy? Well, they are given a calendar, seizure calendar, and you will chart when your seizures happen, every time that a seizure happens during the month. And you will also chart your menstrual cycle and the time of ovulation. Now that could be done with either an ovulation kit that determines when ovulation happens, or the basal body temperature measurement. When the temperature goes up in a certain part of the month, that would be the time of ovulation. If you calculate the number of seizures and there is a cluster of 2 times or more the number of seizures around a certain time of the month, then this patient has catamenial epilepsy, and that's how we determine if somebody has that. Usually we chart at least for 3 months before we make that determination. So some people have worsening of their seizures at a certain time, but it's not necessarily catamenial. It has to be at least 2 or 3 times more seizures around that time. So what is the effect of estrogen and progesterone? Estrogen is the bad hormone, or convulsant hormone. It can lower the seizure threshold, and it can increase the frequency of interictal spikes on EEG. It can increase the seizure frequency. Progestins or progesterone, they are anticonvulsants, so they protect against seizures. The cause of catamenial epilepsy is that both estrogen and progesterone, the hormones that basically are naturally in body, they have effects on the brain. They have neuroactive effects on the brain. So especially they may affect certain parts of the brain that are involved in epilepsy that are very the parts that are irritable, the parts that can cause epilepsy. So the effect of estrogen and progesterone are directly through the brain and in areas of the brain that are susceptible to epilepsy. That's how they work to make seizures worse or better. This is what we call HPO axis, the hypothalamus, anterior pituitary, and ovaries. And the HPO axis is how hormones are made. You have a precursor in the part of the brain, deep nucleus of the brain called hypothalamus. Those precursors make the pituitary gland to make LH and FSH, and those are hormones that can affect ovaries. There's a cycle which makes the follicle in the ovary to grow into an ovum, and then if pregnancy happens, then there's a conversion to corpus luteum during the ovulation. If pregnancy happens, then that continues. If not, then that ovum regresses, and that's when the bleeding happens. So all of these are in the control of the brain, basically, because hypothalamus and pituitary gland in the brain are the ones that are making these precursors of these hormones. So what are the effects of seizures on sex hormones? Seizures may disrupt the HPO axis. So the structures in the brain, they are interconnected. When you have consistent stimulation and irritability in certain part of the brain that is involved in making those hormones, that stimulation, that activity can affect basically the sex hormone production. So the sex hormone can be out of whack because of the seizures. There's a higher rate of reproductive disorders in patients with, in women with epilepsy. They can have higher rate of polycystic ovary. In the general population, polycystic ovary happens only in 4 to 7%. In women with epilepsy, it can happen in 10 to 25%. So that's how seizures can affect basically hormones. Hormones can affect the structure of cysts in the ovaries. They also can cause abnormally long or short menstrual cycle intervals. They can decrease sexual desire. They can also affect the fertility and ovulation. So all of these, the things that seizure does, can affect sex hormones. Now, not only the seizures can affect sex hormones, seizure medications can also affect sex hormones. There are certain medications that can elevate prolactin. There are certain ones that can affect basically the ones that are enzyme inducing, such as carbamazepine, phenytoin, those like older medications. They can affect the liver and they can reduce the amount of sex hormones in the body. Valproic acid is known to cause polycystic ovary. Sexual dysfunction can happen as a result, and early menopause is known to occur in women with epilepsy. So the average age of menopause in women with epilepsy is lower compared to general population. What are the clues to reproductive dysfunction? So if you have weight gain more than 10%, if you start noticing increased facial hair, body hair, if there is hair loss, scalp hair loss, if you have menstrual cycles that are either too short or too long, like and if there is intermenstrual variability, like one cycle is 23 days, the other cycle is 35 days, like from cycle to cycle, you have variability. If there is mid-cycle bleed, and if there is any trouble with sexual desire and arousal, so all of these are signs that something is wrong with the reproductive function, and this needs to be brought up to the attention of the physicians, either the gynecologist or the epilepsy doctor, depending on what symptoms are. Now, that brings us, the second subject that I want to talk about is the effect of seizure medications on contraception. And that's absolutely important to know. When you are on seizure medications, can this make the contraception fail? Can I become pregnant if I am on a seizure medication compared to another seizure medication? So this is a chart that is basically summarizing certain medications that can worsen, that can make the contraception fail. So if you're on oral contraceptives, if it's not a barrier contraceptives, you're on hormonal contraception. Then if you're on carbamazepine, if you're on Onfi, clobazam, eslicarbazepine, that's Aptium, oxcarbazepine, phenobarb, phenytoin, primidone, and rafinamide. These are the medications that if you're on them, you have to have a second method of contraception in addition to the hormone, or just don't use the hormone, use the barrier method, because these basically make the contraception weak. There are other medications such as felbamate, prampanel, or Fycompa, and topiramate or Topamax. These medications, if you take them at higher dose, that can make the contraception fail. And the green is basically seizure medications
Sazgar,
that are.
I think your slides are stuck. Sorry to interrupt you.
Where is my, what are you seeing?
We're on the blue and red slide, contraceptive failure and AEDs. We don't see the charts. I just wanted to let you know.
Okay, let me go back. You see it now?
No.
So you saw the contraceptive failure and AEDs, but then the second.
Yep, we're right there. Yep, contraceptive failure and AEDs, where it says some AEDs result in contraceptive failure.
So I am now on the second one and you cannot see it.
No.
That's weird. Do you see it moving at all to the next one at least? Okay.
No, so maybe what you do is unshare and then reshare your screen. That worked in another.
Let me do it again.
Sorry.
That's okay. No, thanks for telling me, because I have no idea. I think that you're all seeing it. So
as soon as you said here in the chart, I was like, uh-oh.
Yeah, and let me know if it happens again. And do you see the chart now or not?
No, now it says it has started sharing your screen. Maybe it'll catch up.
It has a delay. Last time that I shared it took a bit.
Oops. I think I just came. Oh, here we go.
So is it still saying that it's going to share?
Yeah, it's still saying it's trying to share.
Technology.
I know. It says we're viewing your screen, which is really interesting, but
you're not seeing.
If anybody else can see it, if you can confirm, or it's just on my end.
I think everybody else is on mute, right? Or so that is, I don't know what else to do.
Yeah, they said, no, we can't see it. It is loading for me. Okay, yeah, that's what it says. It's loading for me too. It's really trying.
Huh. Did it happen with anybody else?
It happened once or twice yesterday. Yeah, we haven't had it happen today.
The problem is that they're recording too, so they have to edit all this.
I know. Well, maybe I'll try it. Let's see. I don't know what to do here. Let me get the tech person here that's online with us.
I can try one more time to stop and restart, but the sharing.
Okay. We'll see. Oh, there we go. Now you're back.
Okay, do you see the slide?
See now. Yes, we can see the slide. It's got a red.
Let's hope this is it and it's not gonna happen.
We're back.
Again.
Okay, thank you.
So this is what I was talking about, the red, the yellow, and the green. The red means that if you take those medications, you're not, like, your contraception is gonna fail. So those are carbamazepine, clobazam, eslicarbazepine, you go down the list. And then you have the list of 3 medications that only at higher concentrations can cause failure of contraception. And then the green is all the medications that actually do not cause failure of contraception. So clonazepam, etoxaximide, which is Zarantin, gabapentin, and lacosamide or Vimpat. You see down the list, lamotrigine, levetiracetam, Keppra, all the medications done. These are safe. Like if the patient are on these medications, they do not cause failure of contraception. So I'm going to go to the next slide and tell me if you don't see the next slide. Do you see it now? Perfect. Okay. So contraceptive failure as a result of, for our patients for SB was because she was on oxcarbazepine. She was on that red zone. She was on a medication that is hepatic enzyme inducer, which means that the level of oral contraceptive dropped, and then that's why she became pregnant. So the physician who deals with it should recommend before this happens to have a second barrier method, or sometimes we can increase the estrogen component of the oral contraception to make it more effective. However, estrogen is the same medication, the same hormone that I said is bad for seizures. So usually we don't do that in the epilepsy world. So we try to do IUD or some other barrier method in that case. These are certain contraception pills that have extra estrogen in them. So these are the ones that have 50 microgram or more. And then there is medroxyprogesterone or Depo-Provera injections. If you use Depo-Provera, it has to be more often rather than 3 months. We usually recommend every 2 months. And progestin-only tablets are not going to be effective for contraception in women with epilepsy who are on medication. Also, the mini pill, low-dose pill, is not gonna, it may be good if you're on progesterone for your epilepsy, but it's not good for contraception. So you need something stronger. And the IUDs are either copper IUD or they are the ones with progesterone. And we have like Skyla and Mirena are 2 of them that we have on the market. So what about lamotrigine? Well, lamotrigine doesn't affect the amount of hormones, the amount of like oral contraception, but the moment you start on contraception, the lamotrigine drops significantly, especially if this is estrogen, the lamotrigine drops by about 50%. So if the patient is started on lamotrigine, we usually tell them, if you want to go on the birth control, let me know ahead of time so that I can up your lamotrigine. Otherwise, you're going to have a seizure because the levels drop. Again, it's not related to progesterone. So if they are on progesterone, like at Depo-Provera for example, that's not going to happen because the progesterone doesn't have that interaction. And again, the same happens in older women. If they're on lamotrigine and they're undergoing menopause and they're on hormonal replacement therapy, if they're taking estrogen, that's going to affect the amount of lamotrigine in their body. So again, you have to increase the dose whenever either the contraception, whenever they go under contraception, or if they become pregnant. We talked about each year 24,000 women with epilepsy become pregnant. Now, what happens to the seizures during pregnancy? In about 20 to 35% of women with epilepsy, they have worsening of their seizures during pregnancy. In about 55%, there is absolutely no change during the pregnancy, and 10% actually show improvement of the seizures during pregnancy. How about patients who are catamenial? How about patients who actually have fluctuation of their hormones, fluctuation of their seizures with the hormones? Well, there was a study that actually Cagnetti et al. Published in Neurology in 2014, that he actually followed women with catamenial epilepsy and the ones that didn't have catamenial epilepsy. So there were 59 women with catamenial epilepsy, 215 women that didn't have catamenial epilepsy. And he found out that about 80% of the ones that had catamenial epilepsy remained seizure-free during pregnancy, as opposed to only 22.3% of the ones that didn't have. And then when he looked at the number that had better seizure control during pregnancy, reduced seizure frequency, it was about 50.8% in catamenial group versus 8% in non-catamenial. So there is one good news here, that if patients have catamenial epilepsy, catamenial pattern seems to be a predictor of better pregnancy outcome. So when they become pregnant, actually, they will have a better time with not having seizure or fewer seizures during pregnancy. What are the causes of seizure recurrence in epileptic women who become pregnant? Well, the very first reason is that people get panicked and they discontinue their seizure medication. So a lot of times I have patients referred to me, they already know they are pregnant, and the first thing that they did, they lowered their seizure medications in the fear that, you know, this is going to harm my baby, or they stopped it. And that is not the right thing to do, because the seizures as a result of that can be even more harmful to the baby. Sleep deprivation, the anxiety and stress that comes with finding out that you're pregnant, increased estrogen to progesterone ratio, especially in the first trimester of pregnancy, and then also reduced plasma concentration of the seizure medications, because seizure medications can also have increased clearance during pregnancy. They can have the metabolism changes during pregnancy. So you will have a variable amount of seizure medication, lower amount of seizure medication during pregnancy. There is more dramatic change with Lamotrigine. There's also more dramatic change with a few other medications, oxcarbazepine, phenytoin, phenobarb, and levetiracetam. So these are the medications that if the patient is on it, we will do a lot of adjustment during pregnancy. And we follow the serum concentration. The patients who I see who become pregnant, we send monthly level of the Lamotrigine or monthly level of oxcarbazepine. Their medications are checked every month, and we adjust them depending on the individual patients. Our patients, back to our patient, the case that we were following, she had a reduced level of oxcarbazepine as a result of pregnancy, and that's why she started having some auras. As soon as the dose was adjusted up, the seizures stopped, and she didn't have any more seizures. And then after the pregnancy was over, we decreased the dose back down over the next 2 to 3 weeks to the original dose that she was on. My next topic is epilepsy, in epilepsy and pregnancy, is teratogenicity of the medications, or what is the harm to the baby when somebody becomes pregnant and they have epilepsy. Well, there are two categories of risks. One is the dangers associated with seizure itself, and one is the dangers associated with seizure medication. Overall, the risk of dangers associated with seizure are greater risk of trauma from falls, premature labor, intrauterine growth retardation, low birth weight, stillbirth, which the baby does not survive at the time of the birth, miscarriage, fetal hypoxia, and acidosis, and then suppression of the heart rate of the baby. So overall, these risks double in patients who have epilepsy compared to general population. And then the second thing that we will discuss is the seizure medications. So epileptic seizures during pregnancy are independently from the seizure medications can affect the outcome of pregnancy. People who have epilepsy, the seizures themselves, and not just the seizure medication, can result in preterm delivery, can result in low birth weight, small for gestational age. And then if you're on polypharmacy or certain medications such as valproic acid during pregnancy, it can also result in low IQ in the babies, and that is also proven to be the case. So looking at this, stopping seizure medication during pregnancy is not an option if somebody has active seizure disorder, because the seizures themselves can be more harmful. What are the kind of birth defects that we see in women with epilepsy? There are mostly midline face or midline heart and skeletal defects. So this is, it could be a spina bifida, it could be mid-face malformations, it could be cleft lip, cleft palate. It could also be language acquisition delay. In about 1.2 to 6.2%, the babies may end up with problems with speech delay or with developmental delay. So overall, though, these risks is not more than 10%. The entire risk is under 10%. In general population, when I talk to my patients, I tell them pregnancy is a risky business. If you become pregnant, it doesn't mean that you are necessarily going to have a normal baby. There's about 2 to 3% risk to the baby that the baby may not be normal. There may be a problem with the heart, with the brain when they are born. And about 97% of the population have normal outcome of the pregnancy. Now, if you have epilepsy, that risk increases somewhere between 4 to 6%. There are certain seizure medications such as valproic acid and carbamazepine that can increase the risk of neural tube defects, spina bifida, the other name for it. With the valproic acid, it's about 1 to 2%, and with the carbamazepine, it's about 0.5 to 1%. Now, what are the risks of seizure medications? Well, those numbers come from pregnancy registries. So there's multiple pregnancy registries, European, North American, there is a UK, there's specific pregnancy registries of drug companies. And I hope that you see this graph, because that's very important for you to see. This is the result of the North American AED registry. These are patients who become pregnant and who were on these medications. This is Neurontin, this is zonisamide, oxcarbazepine, levetiracetam or Keppra, Lamotrigine, clonazepam, phenytoin, carbamazepine, topiramate, phenobarb, and valproic acid. So all of these medications, these are patients who were on these as monotherapy. And you see the risk if they're on no seizure medications is about 1.6%. And then anywhere from lamotrigine, levetiracetam, oxcarbazepine, zonisamide, and gabapentin, these are low risk. These are about 2% and less. And when you look at anything after clonazepam, you see phenytoin, carbamazepine, topiramate, phenobarb, and valproic acid, you see the risk goes higher and higher. So if you look at the specific risks, you see with valproic acid, it's about 8.9%. With phenobarb is 5.9%. These are the risk of major congenital malformations, meaning that major problem with the baby. Carbamazepine is about 3%, phenytoin 2.8%, lamotrigine 2.1%, and levetiracetam is 2.0. So these are the risks, the known risks so far that we know. The pregnancy registries are ongoing. So every time that we go to the epilepsy meeting, this year it is virtual. So I'm doing the same basically format of talk for them it is virtual, but we will be informed every year about what is the most recent outcome of the pregnancy registries. And every few years, we have a lot more information on this. The lamotrigine itself has increased risk of cleft lip, cleft palate in the babies, about 8.9 per thousand. In the general population, that risk is about 0.5 to 2.6. So there is increased risk of, it's a cosmetic thing, but it is still a problem, and it can happen with higher prevalence with lamotrigine. With topiramate, that risk is 6 times higher, which means that it is basically in the unsafe category for the topiramate. It is the overall risk with topiramate is 4.1%. How about the neurodevelopment? What's going to happen to the IQ of my baby when they, if I'm on medication during pregnancy? Well, the only medication that was affecting the IQ of the baby, of the children, offspring of women with epilepsy, was valproic acid. So the risks when they actually did the IQ test and did the memory tests and cognitive tests on these patients, on these babies up until 3 years of age, and then they went to 6 years of age. Exposure to valproic acid during pregnancy was a risk factor for lower IQ. Also, other risk factors was low maternal IQ, being on polytherapy, more than one medication during pregnancy, and number of convulsive seizures during pregnancy. So the women who had more than, like, had a few convulsive seizures during pregnancy, that also affected the IQ of the baby. So our patient, back to our case, with her medication oxcarbazepine, the risk was low. You saw that in the pregnancy registry, it was less than 2%. And it wasn't alarmingly high. So thank God she was safe. Despite accidental pregnancy, she actually carried to term. And she continued with folic acid during the pregnancy. Other recommendations that we do during pregnancy, we ask our patients to follow up with high-risk obstetrician, and then with the epileptologist, have a close follow-up. We do ultrasound in the first trimester, but the obstetrician does that, and then also between 16 to 20 weeks, they can get the detailed anatomy, and they can choose to do AFP assessment or the amniocentesis. If we put all of these together, 95% of malformations can be diagnosed early on during pregnancy. Other recommendations, when possible, we will try to simplify seizure medications to only one and to the lowest dose before somebody becomes pregnant, if possible at all. And then we do close monitoring. We do some baseline levels of the seizure medications and then monitor during the pregnancy to adjust the seizure medications. And there are certain medications such as phenytoin and valproic acid and carbamazepine that we can measure both the free level and the total level in the blood. And finally, that brings me to breastfeeding and pregnancy. And we have some good news and new data on breastfeeding that I'm going to share with you. Basically, we know that breastfeeding is good. It can reduce infant mortality. It can boost the immune system of the infant. It can reduce the risk of diabetes in the baby. It can enhance cognitive function of the baby. So the current recommendation is that mothers should breastfeed infants for the first 12 months of life. Now, there's this monitor study that's ongoing, and there was an interim analysis that was published just the end of 2019 about breastfeeding and pregnancy and what happens to the babies with breastfeeding. And what they did is that they had 351 women who enrolled, 345 infants of these women were enrolled. They measured the medication in the blood of the baby and the mother. So it's like at the same time that the mother is breastfeeding, and then what is the level in the blood of the infant. And they did that for carbamazepine, oxcarbazepine, for like a bunch of other medications. And they had 164 matching infant and mother concentration pairs. And they found out that 49% of these infants, they had lower limit of the medication that could be even detected in their blood. So that means that for the majority of these medications, the level was not even detectable in the baby, which means that the baby, it is likely safe to do the breastfeeding. Overall, infant-mother ratio was low, somewhere between 0.3% to 44% compared to what was in the blood of mother. And again, in every single case, the baby level was substantially lower compared to the mother. And the findings, basically the recommendation was that breastfeeding of infants by mothers with epilepsy taking these seizure medications is actually pretty safe. So our patients, SB, gave birth to a healthy baby girl and continued breastfeeding for 6 months after the delivery. There was no encountered problems. Had some auras after the birth of the baby, and again, it was due to sleep deprivation and the stress. There was some adjustment of the seizure medications, but she did well. And then after this, she chose to use IUD with progesterone release, so that the next time she wants to become pregnant, at least she makes a decision herself, and it's not a surprise. In conclusion, there are particular challenges in managing epilepsy in women, either before they pregnancy, during pregnancy, and after pregnancy is over. But if proper recommendations are followed, the good news is that the vast majority of women with epilepsy give birth to normal children. A lot of my patients, they have happy, healthy children, and they were on medications during their pregnancy, and we managed to pull through, and they're doing well. And we need to keep raising awareness about women with epilepsy. It's a whole different set of issues, and people need to become comfortable with that. It's something that is ongoing, and I think we should keep educating both the public and the caregivers and the practitioners regarding this. This is a very old picture of us with the Epilepsy Support Network, and my son that you see in there is now like much taller than me and my husband. So this is, I think, about could be 9-10 years ago. And here are a couple of my books. That one was Controversies in Caring for Women with Epilepsy. There is a book also that I wrote about absolute epilepsy and EEG rotation, but there is a chapter in there about women with epilepsy, and in a bullet format, it basically talks about everything that I talked about. And then there's also a continuum neurology that I wrote a chapter just last year, April, on management of women with epilepsy. So without further ado, I just thank you for your attention once again. Thank you for the opportunity to talk on something that I love to talk about. And if you have any questions, please let me know.
Thank you so much, Dr. Sazgar. That was great information. There are a couple questions in the chat box, so I can read them so everybody can hear them, and then
sure,
I'll keep monitoring. Okay, the first question is, I ordered ovulation kits to record levels in my daughter. She is 40 and going through perimenopause. Her seizures have greatly increased. What time of the month should I start the testing? Is there a better time? And additional information is that she definitely has catamenial epilepsy, which previously presented only once a month. She's on 3 seizure meds and has tried many hormone treatments. Any suggestions?
So usually the ovulation kit has instructions, and usually it's like the first day of menstruation, that like basically it is a urine test that you do, and you continue throughout, like it's a daily test. Now there are some of them that are more abbreviated versions. So depending on which one you purchase, you like some of them, they instruct you to do it only like a few days after menstruation, because they have like fewer number of the tests in the packet. So depending on what you purchase, it usually comes with the instruction. The ones that I suggest are the ones that are like the entire month. So basically you're testing, and it does within 1 to 2 days, it does predict that this is the time of ovulation. And it is usually around the time of menopause, when you go through hormonal changes again. That's the time the fluctuation makes the seizures worse. So a lot of people for a couple of years around the time of the menopause, not when the menopause is over, actually when they start to have those fluctuations, that's when the seizures worsen. And sometimes the hormonal changes may or may not, the hormonal introduction of progesterone, for example, may or may not help, because the fluctuation is just too much around that time. But the good news is that usually that settles with the actual menopause. So when menopause happens, when the estrogen level drops in the body, there's some bad things for it that happens with it, but the good things is that it will make the seizures settle more. So again, it's individual cases. I cannot like comment on your daughter separately, but we there are methods that we use, and it may be more resistant around the time of menopause to use those methods, and like sometimes we just need to adjust the medications around that time, or even do like other, like find out what was happening and whether there's any surgical option or other like VNS option, RNS option, other things. So it is not, if a seizure is catamenial, it doesn't necessarily mean that hormone is the only answer. You still have all the other options and hormonal intervention.
Okay, great. Next question is, what if you're on an AED in the green zone as well as the red zone?
Oh, then the red zone wins because if you are, for example, if you're on carbamazepine and then at the same time you are, say, on valproic acid, and I'm just making examples. So valproic acid doesn't fail the hormonal contraception, but you are on carbamazepine. So that fails it no matter what. So the green zone doesn't protect. The green zone just doesn't do anything, makes that hormone stays the same. But the red zone, if you have anything in the red zone, you have to take a barrier method and some, especially even the yellow zone, consider that red zone because a lot of patients are on high doses of those medications anyway. So basically, yeah, the red wins, unfortunately. So you need to use treat it as that both medications are in that zone.
Thank you, she said. So we don't have any other questions in the chat, but feel free to type any questions in the chat, or you can actually just come off mute and ask Dr. Sazgar directly your questions, and we'll give it another minute. And Dr. Sazgar, while we're waiting, did you tell us the titles of the other two books?
These are, are you seeing the slide?
Yeah, we see the one. I thought you had mentioned there was another book as well.
There are two of them. So the one,
there's two up there. Oh, okay.
The one on the left.
I had to move the chat box. Okay, I see. Great. Okay.
And then, yeah, it's kind of funny with the with virtual. You're not sure whether the other side is seeing what you're actually presenting.
You have to move all the little zooms around as well.
But it is a blessing as well because at least we can do the same talk that we, at this point in time, we cannot do in person. So
exactly.
Advantages and disadvantages.
Exactly. Well, we don't have anything else coming in the chat. And we'll give it another minute to see if anybody wants to come off mute. But again, thank you so much, Dr. Sazgar, for joining us and sharing all this wonderful information.
Absolutely. Thank you, Tarish.
There's a lot of
thank you, everyone.
Coming in. Yeah. Oh, here we go. We have one that just came in, too. Have you found progesterone cream to be beneficial?
The progesterone cream works for some people, not for everyone. And again, I usually do like 20 gram, and that is like twice daily. It depends on the patient. Sometimes it's around the time of the worsening of their seizures that they use it. I have a patient who just uses it throughout the month. So it does absorb. It does do the same thing that basically if oral progesterone can do. So I find it very beneficial in certain patients. Again, it depends on the individual. A lot of these things are not written in stone. It's not something that, it's like medication. The same medication may help somebody and may not help another person. So it's worth trying.
Mm-hmm. Okay. Next question is it common to have seizure amount heightened during both times in the cycle?
Yes, it can happen. Some people have both C1 and C2. So they have both around the time of ovulation and menstruation that have a worsening of their seizures. Because there are two different reasons. One is the estrogen peaking and the other one is progesterone dropping. So yes, you can.
So it's a big balancing act. Okay.
In fact, I have quite a few patients who have both.
Okay. That's all we have in the chat box. So if anybody doesn't have any other questions, this is fantastic talk. Really appreciate it. Thank you, everybody, for joining us.
It was a pleasure talking to everyone, and thank you again for inviting me.
Okay. Thank you, everyone.
Bye-bye.